And I've also been a palliative care physician for many years, and also studied classical medical ethics and have practiced that. And so I've been really interested in this aspect of taking care of cancer patients. And the name of my the title is "The Care Doesn't Stop with the Chemo: Supportive and Palliative Care Throughout the Cancer Journey." And so the objectives are basically to use a case of a patient by the name of Mr. John Sidham, obviously not his name, to illustrate sort of some of the things about using palliative and supportive care throughout the cancer journey. And I want to just say that this whole idea of supportive care really is a fairly new concept, and it basically came about because whenever people say the word palliative care, a lot of patients equated that with hospice and their families. And so people, especially with cancer, when they heard somebody say, well, let's get palliative care to see you for your pain or for your chemotherapy associated nausea and vomiting early in the cancer trajectory, they would be like, I am not seeing palliative care. I'm not dying here. I'm not going to hospice. And you'd be like, no, 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 it's not that. So then pretty soon throughout the sort of oncology community, people started saying, let's just say supportive care, because then it sounds so neutral. It's more, it describes what we're doing, but it's not palliative. That sounds like hospice. So I just wanted to say that's why we say supportive care sometimes, but it's really providing the same type of care. And I just wanted to talk about selected palliative specific issues in cancer care. Sorry, management of selected symptoms, a little bit about discussions of goals of care, the importance of prognosis, and shared decision making. These are, just a few of the common symptoms during the cancer journey. And like I said, these can occur very early on. When somebody, say with breast cancer, who has never seen the inside of a hospital, except maybe to have their surgery, is getting their chemotherapy. But they can develop a lot of these symptoms. You don't have to be at the end of life to get some of these symptoms, especially things like constipation, diarrhea, hiccups, neuropathy, anxiety, depression, spiritual suffering. I mean, that can happen anywhere along the cancer journey. So whenever we say palliative care, we have to remember this is not hospice. It just is providing really good symptom management. And on the other side of things, it's sort of two-pronged. One prong is the symptom management, and the other prong is sort of the affective prong, is talking with patients, learning about them, involving the chaplain, involving the nurses, involving other people, the therapists to help take care of them. So palliative care is very interdisciplinary, as you can imagine. It does take a village to take care of a person with cancer. The World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, stress early, and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And notice that this World Health Organization definition doesn't say anything about timing, doesn't say anything about end of life, anything like that. They say life-threatening illness, but they never say where it is in the cancer trajectory or the cancer journey. So I think that's really important. Palliative care can be applied at any time. What palliative care does is to provide expert relief of suffering, involve and support the family, focus on complex and advanced illnesses, coordinate and rationalize care, help clarify and set goals with the patient and family, help to make the system responsive to patients, and provide alternatives to purely curative care. What it is not, it doesn't seek to delay or advance death. Some people think that palliative care, if you get palliative care, then they're just going to come in and give a whole bunch of pain medicine and, cause people to die earlier. That's all they are. And that's not true. It's not giving up on a patient. It's not opposed to curative or life-prolonging care, and it's not tied to the Medicare hospice benefit, as I said. It's not synonymous with hospice at all. But hospice is basically a way to provide palliative care in the last 6 months of life. And so while palliative care isn't hospice, hospice is really a way to provide palliative care. I think that's my easiest way to look at it. Palliative care does involve helping people with advanced planning, and providing compassion, support, and education along the continuum of care. And you can see that you can go anywhere from a patient being healthy and independent, and you can stop right there. A patient can continue to be healthy and independent and get palliative care while they're getting their chemotherapy or their surgery or their radiation and never move on down this line. But they may move to chronic disease, functional decline, advancing chronic illness, multiple comorbidities, advancing frailty, and death with dignity. And palliative care can be with a patient throughout this whole continuum. So back to John. He's our 76-year-old man diagnosed 6 months ago with non-small cell lung cancer, received chemotherapy and immunotherapy for 6 months, and he had a partial response of cancer in the lung. He complained of severe left rib and right hip pain, both of which had metastatic deposits in the bone. He was treated with hypofractionated radiation. And that is a concept that started probably about 15 to 17, maybe 10, 20 years ago. And it's really taken hold across the country and across the world. And when they looked at a group of patients who got hypofractionation, which basically means that instead of multiple fractions and hyperfractionation, where you have like 20 fractions over the course of 3 or 4 weeks, versus 1 or 2 fractions, so hypofractionation for bone pain, that 40% of patients experience pain reduction and better quality of life at day 10 after the hypofractionation, and with further improvements in quality of life by day 42. So how the authors concluded at the end of the study, where they pitted the hypo versus the regular radiation therapy, they said a single 8 gray, which is a lot of radiation at once, radiotherapy dose for bone metastases should be offered to all patients, even those with poor survival. So you can only imagine that if they only have to go in maybe for 8 gray or 2 doses of 4 apiece, they only have to go into the radiation dock a couple of times to get their pain symptoms, their bone treatment done, versus going every day, which is extremely tiring, especially if they're traveling 1 and 2 hours a day. That hypofractionation is really worth it. The one thing that's come out of this, as they've studied it over these years that they've been giving it, is that often patients have their pain returns after several weeks, and they have to get 1 more dose of hypofractionation. But it's probably worth it versus going for, every day for 8 days or 10 days or 15 days to get smaller fractions of radiation. And it doesn't seem to do anything different to the bone. So that's really helpful too. And so it really saves the patient time and gives them more time to spend at home, time off the road, probably saves them money, and time that they can spend at home with their families. So that's a really cool concept I wanted to tell you guys about. So 3 weeks later, after he has his hypofractionated radiation, he's feeling better from the bone side of things, but he reports to clinic with worsening shortness of breath. He's beginning to have to sit up in a chair at night to get his breath while sleeping, and over the past 6 months, he's lost 29 pounds. And we all know those patients, lots of weight loss, advanced cancer. You see him in the clinic, and he's afebrile. His vitals are, remarkable for tachycardia and tachypnea. His O2 saturation is 89%, so raise your eyebrows a little. He looks frail, he looks tired, he has mild temporal and infraclavicular wasting. He has a firm left 2 centimeter supraclavicular node. He has diminished breath sounds in his left lower lobe and a firm liver edge at the right costal margin. He's got generalized muscle wasting in his extremities. His cranial nerves are intact, but he's got kind of a slow gait. His affect is very restricted. He doesn't smile or laugh. He just kind of is not very interactive. So the next step, the first thing you want to do is get his oxygen under a little better control. So you add some oxygen by nasal cannula. He's still short of breath. His SATs have come up a little bit. His respiratory rate is still quite high. So the next thing to do when you're thinking about dyspnea in a person with cancer, especially lung cancer, but many other cancers, is to detect the underlying cause. And if it can't be fixed, to concentrate on controlling the symptoms. So if you can't fix the cancer, which we're not really fixing his cancer, but trying, but just not fixing it because it's pretty resistant to treatment. His respiratory rate and oxygen saturation level are not reliable indicators of the presence or feeling of dyspnea. And we always have to remember that even if we see the oxygen level come up to, say, 95%, that they're still saying, I'm really short of breath. I'm really short of breath. You have to believe them. Why would you always have to believe the patient. It's like with pain. You have to believe what they say about how they feel. Only they know how they feel about anything. So dyspnea has physical and affective components, as you can imagine, because it makes people very anxious and it's very frightening to be short of breath and to feel like you're suffocating. So you get a chest X-ray and you see this pleural effusion here at the base of the left lung, and then you say, well, let me just go ahead and get a CT. So you see this big massive cancer and cancerous nodes here in the back of his heart. And then here's this pleural effusion, this collection of fluid right here. So he's got a pretty good malignant pleural effusion going. Some things that you can consider if he's still dyspneic is a small dose of morphine, which, 5 milligrams, something like that, PO, or 3 milligrams IV for his shortness of breath, sometimes helps to sort of decouple what his brain feels versus what's actually going on in his lungs, and sort of helps him feel less dyspneic, less uncomfortable. Some people over the years have used nebulized fentanyl, where you take 25 mics of liquid fentanyl, dump it in a nebulizer and nebulize it. And sometimes that really helps, again, sort of uncouple those sensations. You plan a thoracentesis. You're going to get rid of that fluid in there, see if that will help. And then probably not go on to do another procedure, but probably consider just watchful waiting, because sometimes if you take the fluid out, it may take a really long time to reaccumulate. So you don't want to necessarily have him, subjected to another procedure that he doesn't really need. But some of the procedures that you might think about are thoracostomy pleurodesis, Pleurex catheter, or a VATS pleurodesis, where you actually go into the pleura and suck out the fluid and then put in some talc to close up the pleura so that he can't let that fluid reaccumulate again. What's the best treatment? I don't think anybody still knows. It depends on how rapidly the fluid reaccumulates, what the patient will tolerate, what's available and practical in our state. Sometimes it's really far away that you're going to find somebody who can do a talc pleurodesis with a VATS procedure. So it kind of depends. Does the patient want to stay in the hospital for a long time? Because if you put a chest tube in, they're usually going to be there for 5 to 7 days, draining the fluid and then doing the actual, talc insertion and then waiting for that to work. What's his prognosis? Is he really close to death? Do you want to do any of those things, or do you want to just treat him with morphine and oxygen and whatever else is needed to help his anxiety and not put him through a procedure when it's his last, 7 days of life? So, and what does he prefer, of course? What does he and his family prefer? I just wanted to mention the pleural catheter is one of my favorites because the patient can control it at home. They don't have to come in for various things. And what it is just a little catheter that goes into the pleura, drains out the fluid, and the patient can just open that little drain up over the sink or the toilet, let that fluid drain out, and then close it back up, and they're done. And they can do it whenever they are feeling really dyspneic, or their family can do it. And it's very easy to learn. And my patients have had really, really good luck with this. So I've always been sort of a proponent of the pleural catheter. Some people call them Pleurexes. That's the trade name. So you do a thoracentesis. His dyspnea is much improved. He goes to his oncologist later that week and he says, let's try another round of a new kind of therapy. And he says, what do I have to lose? So you hope that his oncologist has sat down with him and talked about the pros and cons of the therapy versus not doing the therapy and then just and focusing on quality of life. Um, and so, you know, that's where the art of medicine comes in. So he receives the 2 cycles of chemo and immunotherapy on a clinical trial, but his effusion returns and his liver is actually growing. He decides to have a pleural catheter placed and forego any further cancer-directed therapy. And I just wanted to mention, shared decision making is so important when patients are deciding on such big decisions as stopping, cancer-directed therapy or other decisions, such as, do I want a pleural catheter? There are lots of those are huge decisions, each one of those. So you think about autonomy with the patient making all the decisions, or paternalism with the doctor making all the decisions, and neither one is very helpful by itself. So shared decision making is the best model to me. It's the current model. The clinician imparts the medical and clinical information. They tell them all the pros and cons of each, approach. The patient imparts their values, their wishes, their expectations. The decision is the outcome of the process of conversations based on input from both. And what's really important is not usually input from just the oncologist talking to the patient, but input from the chaplain, the nurses, the people taking care of them, of course, their family, and especially their primary care physician. And I can tell you how many patients I've had that when I sat down and talked with them about a big decision, they wanted to go and talk to their primary care physician or primary care APP, who they have worked with forever, who's taken care of them and their family, and who they just trust implicitly. So that fiduciary relationship is really key to successful shared decision making. Let's see. And what's very important is the prognostic understanding. Patients with a real prognostic understanding are not only more likely to prefer comfort-oriented care, but also more likely to engage in advanced care planning. And patients who perceive themselves to have a longer life expectancy were less likely to complete a living will or appoint a healthcare proxy. And prognostic disclosures are associated with more realistic patient expectations without decrements to their emotional well-being or the patient-physician relationship. So it's really, really important to tell the patient the truth, the patient and the family, and to do it gently and kindly, but honestly and candidly, so that they know exactly what they're dealing with and they can make decisions based on reality and not based on some sort of, as they always say, don't mess around with this, or don't I can't think of the word that they say, but they don't want you to sugarcoat it. They always, the patients in Iowa used to always say sugarcoat. I don't know why, that must have been an Iowa thing, but they always say, Doc, don't sugarcoat it. Just tell me. And then you'd tell them and they would be like, thank you. It was never, I hate you. Why did you tell me that? It was always, thank you. You're the first person that's told me the truth. And so people want to know the truth so they can make decisions based on the truth, not based on sort of some sugar-coated thing. I hope that makes sense. So now John says he's very tired and weak. He has no appetite. He's continuing to lose weight. He's sad. He's withdrawn, even when his daughter and sister visit. And his daughter says, Dad's getting so skinny, he never eats. Do you think he could be put on a feeding tube? So we think about anorexia and cancer, and that few measures in late cancer are successful to improve appetite or gain weight in advanced cancer. There's more stuff coming out that in not so advanced cancer, where patients are still maybe getting chemotherapy, where their prognosis can be measured in several months, that potentially helping them with even tube feedings, or at least supplements and things like that, may help them have a better quality of life, may help them gain a little bit weight or stabilize their weight. But when they are having advanced cancer like Mr. John Sydenham, it really, there's no need to, and it's useless really to give them a feeding tube. It really hurts them basically. Tube feedings haven't been shown to improve life expectancy or quality in late stages of cancer. There's all this presence of cytokines that really come between the liver being able to process the food into storage products like good protein, good muscle. They also interact across the blood-brain barrier with areas in the brain endothelial cells to reduce or block hunger. And sarcopenia is sort of the coming concept that people are starting to talk about more and more. It's important to consider versus simple weight loss. And it's affected not only by the cancer, but also by cancer treatment. It's very interesting. And I'll just say that tube feedings are uncomfortable. They cause bloating and diarrhea, leading to frequent changes, cleaning, leading to skin breakdown. Tube feedings do not ameliorate the risk of aspiration. Intravenous feedings increase the risk of infection, electrolyte imbalance, and necessitate frequent blood draws. Artificial nutrition may significantly contribute to discomfort and have a negative impact on quality of life. And remember that cessation of appetite near the end of life is part of the dying process, and education is really critical. And talking with the patient, and especially with the family who, is saying, why isn't he eating? Why isn't he eating? I've made his favorite things. He just won't touch it. So John is sad most of the time. And we know that 50% or more of patients with late stages of cancer experience depression. It's very difficult to discern depression from grief. And the management is sort of multifocal counseling, spiritual, psychological support, mild exercise if possible, family visits, and then considering an antidepressant. And sometimes you don't have enough time for an antidepressant like an SSRI to work. And so something that is really helpful is methylphenidate or Ritalin. Just a little dose, not a big dose, 5 to 10 milligrams at 8 in the morning and 12 noon to improve mood, energy, psychostimulation, while waiting for the classic antidepressant effects of the SSRIs or others to work. It has a very rapid onset of effects. It often improves alertness, brightness, increased physical and psychic energy. Some people used to think that even improved appetite, but then another study sort of put that to rest. But it definitely doesn't go against appetite. It just doesn't improve appetite. It has a short half-life. So if the patient doesn't like the effects that they feel, maybe they feel a little bit irritable or nervous from it. And it's not common because it's not a very big dose, but if they don't like it, it'll wear off quickly and they don't have to take it again. So he started on the methylphenidate, and he's also started on mirtazapine, which will probably take effect for, in 3 to 4 weeks, maybe 6. And he does a bit better over the next few weeks. One morning, his daughter calls you and says, Dad's in so much pain, I don't know what to do. So you send him to the emergency department. He's very still. He's quiet, he's withdrawn. He rates his pain 12 out of 10. He's been taking a lot of oxycodone, no relief. His exam reveals the lungs to be clear, the pleuric catheter is in place. You get a CT scan. and his liver is packed with metastases, and it's huge, and it's probably pressing on the liver capsule that surrounds the liver and causing all that pain. I just wanted to say a couple of things because the treatment of pain is, a seminar, like a week-long seminar. But if it's severe pain, they always need admission. It's not call in something or have them double their oxycodone. If it's severe pain, if he's saying it's a 12 out of 10, he needs to come to the hospital unless he really wants to stay home. And probably the best way to get his pain under the best control is to use a PCA. And once you get the optimum dose, you convert it to a long-acting sustained release medication to get him home again, and then prescribe breakthrough opioid about 10 to 20% of that total scheduled dose. And then you reassess him frequently. So his pain is well controlled on 3 milligrams of morphine per hour, 3 milligrams nursing bolus because he's not really able to hit the button very well. Your plans are for home hospice with his sister. The night before discharge, he begins crying out for his wife. He's inconsolable. She died 4 years ago. This is very common. He's trying to get out of bed. His neuro exam's okay. Nothing comes up when you do his labs. And he probably has terminal delirium. And that's not very well described, but you can definitely treat it. He gets some IV Haldol. You wonder about the delirium. Should you work it up? I don't think so. Why would you, subject him to more lab draws and get more consultants in and things like that? You and his family and his chaplain, his pastor, they've all discussed goals of care with him. And he said, I have made amends with my maker. He just wants to be comfortable. So you continue the Haldol and pain medications. Now all changed to IV, and he lapses into a coma and he dies comfortably 2 days later. So that's what I have to say about palliative care in the sort of the cancer journey, whether it's a short cancer journey or a long one. So I'm going to ask you guys if you have questions or comments.
Thanks so much, Laurie. This is, I know it's not a very uplifting topic, but it's an important one. It was actually nurses. Two of my grandparents passed away, one from cancer and one from COVID. And it was nurses who actually told us what was going on at the end, like this type of discussion. And it's important, to know so that you can make decisions. So I appreciate you talking about it.
Sure.
I have one question, Lori.
Yeah.
Just curious, when we're talking about like things like the Plerex and the hypofractionated radiation therapy for the bone pain, how do we have a sense for how often most of our providers are offering those sorts of things? Are we on the sort of like the more the side where we're offering more often, or is it something that maybe there's a space for sort of talking to folks about that so that we're offering it more often when it's appropriate?
Well, between you and me, I would not want to tell the radiation oncologist what to do. And I've seen multiple radiation oncologists practice different ways of providing palliative radiation, bone radiation. And I know they are very much aware of hypofractionation, and some do it, some don't. And I think it's just a conversation.
Okay. Because
And
I know
as far as the other one goes, yeah, I think people do Plerex catheters.
Oh, I
Definitely.
wasn't sure how broad that was, but I know like when I was even working with Jeff Reichman in radiation oncology and at Camden Clark, like we're even doing therapy for osteoarthritis and things like that, like for these chronic pains. So I know we've got some folks that are sort of at the forefront of that. I just wasn't sure where we were sort of as a general organization. So that's kind of interesting to know.
Yeah, I think we're okay.
Okay.
Look at you warriors that hung out with me this whole time. Thank you.
Yeah, no, thank you. I have a question just about your role at the Cancer Center. So you are the palliative care person. And do you have others kind of working with you? Or, how do you meet all the needs at the Cancer Center for palliative care?
Oh, I don't do palliative care except when I'm, when I'm on the inpatient service, I will teach because I've done palliative care so much part of my life. But no, I'm not part of the palliative care team
Well,
here.
thank you for the clarification. I
Yeah,
appreciate
I
that.
wish I was
Maybe I
sometimes,
just
but
stuck that in my head when they first introduced you.
oh
Yeah,
yeah. No,
okay.
but I do try to teach the palliative care try to teach palliative care to the fellows as we see patients and the residents, et cetera, when I've been on TCT as well as when we're on the inpatient consult service. We talk a lot about how to speak with patients, how to, pain management, symptom management, things like that. But yeah, no, I'm not the palliative care person.
Okay.
But thanks for asking.
Yeah.
I appreciate all your comments, Dr. Lacombe. And I think, one of the audiences for this echo is the primary care population. So I'm thinking about your mention of educate, educate, educate. I mean, I think you did a lot. Your presentation covered a lot of areas and opportunities and in very important times to ask questions and to consider the benefits of different alternatives. So I'm thinking about this specific instance, but also even more broadly in our state. So if I'm a primary care physician, maybe not as closely tied to a specific cancer center and a little further away, what should I take away from this type of conversation and keep in the forefront of my mind to make sure that I'm thinking, exploring the potential? Like I'm trying to think about our more rural providers and the environment where they may get questions that could be directed through other places, but like when to refer on, when to think about what they could do to help complement this, just anything you could think about that could kind of complement this discussion and expand the conversation around how do we help people in our areas of the state that are harder to reach, and even where the providers are maybe have more limited resources, and thinking about those groups as we're talking about this topic.
That's great. I thought about that the whole time I was writing this talk because having worked in a rural area once a week for about 20 years, I worked on the Chesapeake Bay way out, and I spent so much time communication, and a lot of it is communication. A lot of those things that I brought up are more that things that primary care physicians can do. Sure, they can't do hypofractionated radiation, but they can know about it, and they can know, about sort of when to not refer the patient, when to refer the patient, how to treat pain. You don't have to be a palliative care physician to treat pain unless you've got something really complicated like methadone. Most non-palliative care people don't want to use methadone because it's very dangerous, but it's really effective. Or, intrathecal pumps or things like that that palliative care people should basically do. But I think a lot of it is encouraging people when they have a cancer patient to call the oncologist. I just don't think that there is as much communication as I wish there would be, where you can call the oncologist and say, hey, now he's really confused. I think he's really terminal. What do you think we should do? Well, maybe you should try some Haldol, or maybe you should try some Zyprexa. And maybe those things are, all they need is just a little push, is just a little permission to use those medications rather than transport them, etc. So I think communication is always at the root of everything. I mean, look who I'm talking to. So that's what I think.
Thank you.
Thank you. Well, thanks you guys. This has been really fun, and thank you for holding on with me. I really appreciate it.
Absolutely. Thank you. Great presentation.